All right, so I am going to stop talking. I'm going to turn it over to Dr. Stanford. He's sharing his screen, he's in control, and we will listen with bated breath, and then we'll come back here to ask our questions in a little bit. So take it away.
Wonderful. Thank you, Anne. I appreciate it. Um, and bear with me, I'm not great with sharing screen and Zoom, so we'll see if I can make this work. So the lecture tonight that I wanted to give was just discussing a little bit about orthotics for kids, treating common pediatric pathologies. And my email address is part of the webinar. If people have questions, like feel free to send me an email. I love chatting about stuff. I just want to get people thinking a little bit today. Obviously, we're dealing with practitioners with different levels of experience with pediatrics, and I was asked to speak by Louis DeCaro, the head of the American College of Foot and Ankle Pediatrics, and absolute brilliant biomechanics pediatric podiatrist. And so I'm kind of in his shadow. He's somebody that has been a great mentor to me, along with his partner Roberta Knoll, and so I really appreciate them. There's so many wonderful people in podiatry that share so much about biomechanics that really help mold my approach. And so I wanted to like have a little bit of fun with it tonight too. So if we're looking at so a little bit about me, I did graduate from the Ohio College of Podiatric Medicine, now the Kent State Podiatric School, in 2008. I did a PMS 36 residency at Cleveland Lewis Stokes, the Veteran Affairs Hospital. And I'm still grateful for all those wonderful attendings and people that I worked with there. I did, I just wanted to mention too that practice in Canada is a little bit different. And so I practice in Langley, which is a bit of a suburb of Vancouver. So we're on the West Coast, maybe 45 minutes outside of Vancouver. And we have centralized healthcare. So primary care doctors and hospitals and those things, they're all free basically, and specialists and certain things. And so we're outside of healthcare. We're part of what we call extended benefits. And so people will have medical benefits for dental, optometry, things like that, that they get through their work, and we're kind of parceled in with that. And so we're fortunate that people in general have coverage, although most of the patients that I see are working age patients or people who in retirement, they opted to pay for a policy. So it's a little bit different from the US. Here in Canada, in BC, we do not practice in the hospital. We are not welcome in to do surgery in those types of settings. We can do surgery in like outrageously overpriced surgery centers. My colleague, Dr. Sandar, is the surgeon for our practice, and I happily refer all the surgery to her. She's wonderful. But so my approach for a long time has been very much more biomechanical, and people here have really good coverage for orthotics in general. And so I do have that benefit. I do typically about 1,000 orthotics a year. And I've been in practice for, oh goodness, about going on 15 years. And so I haven't been in practice that long, but long enough to kind of develop my own take on things. And I just love working with pediatrics. I've been attending the ACFAP for a long time. If anybody's looking for a great conference with just a nucleus of absolutely brilliant people are willing to tell you everything they know and answer questions, any question that you could possibly have. You really need to check out the ACFAP. We get some students and residents that attend every year, really try to go out of our way to make them feel welcome. I hope that, I think that almost everybody attending that conference knows who I am. If I don't know you, I'm going to try and meet you. So it is an amazing conference. And so I just want to put a big shout out to those guys. So practice in Canada, a little bit more primary care podiatry from my perspective, and I do a lot of orthotics, and I really, really enjoy working with kids. So I want to start off with a fun slide. This is Nano Banana that helped me create this, although part of the primate's foot cut off a little bit. So why custom foot orthotics in general? I think that we leave medicine, we leave residency in school having a really firm grasp of pathology and surgery and understanding a lot of things. And I think that sometimes biomechanics is a little bit of a mystery. And we're learning words like, maximally pronating the oblique and transverse metatarsal joints. And we're really talking about locking the talar navicular joint and calcaneal cuboid joint. And I really wish, if I was teaching biomechanics, which I had a wonderful biomechanics teacher, thank you, Dr. Spencer. But if I was teaching it, I'd probably have kids put a model on their desk like anatomy and kind of move it around and talk about what's going on with the foot while we're doing things. Because being able to conceptualize what's happening, why the foot is so special is great. So I thought this is a good illustration. Most mammals walk and run shortly after birth. You see, the birth of a colt, and it's immediately like running around the yard. And humans, on the other hand, take several months before taking our first clumsy steps. My 2-year-old Allison was super lazy, and I think she like laid on her back and rolled around until she was about 11 months old. And I came home one day and she was finally sitting up and testing with walking, and eventually she walked on time. But walking is a really challenging thing for humans, and it's because we have this this remarkable adaptive sensory appendage on the bottom of our leg, okay? And it's through proprioception that we're able to balance and walk on only 2 limbs instead of 4, and it allows us to dedicate our hands to using tools, weapons, instruments, etc. So when anthropologists talk about what separates us from Neanderthals and all our different primate relatives, they like to focus on our brain mass. But I really like to talk about the fact that we can use 2 hands as part of why we became the apex predator, and we can do that because we have this truly, truly remarkable appendage, the foot at the bottom of the leg, and it is different from other animals. It moves, it absorbs shock, it transitions into rigidity, and so it really is one of the defining features of humanity. So it's a great thing being a podiatrist working on feet because they are amazing. So this is a joke. One of my staff made this T-shirt for me for Christmas time, and it's something I used to say to patients all the time. I probably say it less often now, but the problem with our feet is the ground, and so it's hanging up in my hallway. It's a great T-shirt. The problem with the foot is the ground. So anthropologists would argue that we've been walking predominantly on hard surfaces for only about the last 70 to 100 years. Prior to that, about 4 to 5 people were working somewhere in the agricultural industry. And around the turn of the century, people started migrating to these large urban centers, and the ground that we walk on has become increasingly hard. And I would argue that the dysfunction of the foot is in great extent, not the only thing, but it is a significant factor, relative to the ground reactive forces of the surfaces we walk on. And hence the joke, the problem with the foot is the ground. Of course, if the foot didn't touch the ground, we wouldn't have very many issues. But because the ground has progressively gotten harder over time, it's become more and more problematic. And we're wearing out joints faster than we ever have before, hips and knees, and we are not nearly as active as we used to be. And so it's a byproduct of the surfaces that we're on, we think, in biomechanics circles, that contributes so much to this degradation of the body, that we could really blame cement for it. And I tell patients all the time too that hardwood and tile has been really good for business. And so I think let's just make houses as hard as possible. It's great being a biomechanics podiatrist as the surfaces we walk on just get harder and harder. This is another AI photo that I'm probably going to make these into posters in my office. I love this goofy stuff. So the orthotics are like putting our footprints in our shoes. And I use this analogy to discuss motion of the foot quite a bit with patients. And I recognize that like everyone leaves a footprint in the ground, whether we're supinating or not. But it helps them just kind of imagine when we're walking on a softer surface, the foot functions a whole lot better. Now, obviously, wet sand is very soft and it'd probably be exhausting to walk on. But our gait involves the coordinated muscular and connective tissue engagement, much of which takes place without conscious effort. In nature, we would supinate the foot more effectively on surfaces, allowing us to press the foot into the ground. And so, it's funny with in 2008, there was the barefoot revolution after an anecdotal book was published that really made us look closer at barefoot ambulation and gait versus shod gait. And I think it's been helpful for the shoe industry in general. But people kind of see me all the time and they're like, well, aren't we supposed to be walking around barefoot? Like, why would we want to wear orthotics? Why would we want to wear shoes? And there's no question. We are meant to function barefoot. We're just not meant to function barefoot on hard surfaces. And in the modern age, we walk almost exclusively on one smooth rock all the time. And so it's the extraordinary ground reactive forces, cement, hardwood, tile, etc., that leads to greater dysfunction of the majority of feet. Therefore, the custom orthotic is like putting your footprint inside your shoe. We're going to limit excessive pronation. We're going to encourage proper supination. We reduce stress on tissues. We lessen muscular overuse. We raise threshold to injury. We improve function and performance. I oftentimes will tell patients that the purpose of the orthotic is to help you function as though you're walking around barefoot, leaving footprints in the ground despite wearing shoes on hard surfaces. The whole concept. The orthotic is supposed to help the body what it's already trying to do. We don't need to teach the body anything new. It's doing these muscles are firing in concert the way they're supposed to. It's just they're obfuscated by the surfaces that we walk on. And the ground reactive force of very hard surfaces is really detrimental to foot function. So this is the footprint analogy. This is a repetitive script that I use to describe foot motion to patients. We'll demonstrate foot motion on them while they're sitting in the chair in open kinetic chain. I recognize the foot functions in closed kinetic chain. This isn't perfect, but the intention is to help them understand the transition between the mobile adapter and rigid lever of the foot. It's this adaptive appendage. It's quite remarkable. And the triplanar motion of the foot taking place. So trying to identify all three planes of motion so they can understand that it's not just an arch issue. There's a whole lot going on. I've really found this to be helpful, illustrating the benefit of a custom orthotic. I've shared this with some of my peers. Some of them think I'm nuts, and other ones really attach to this. But if you work in my office, you'll hear me give this discussion at least a dozen times a day to patients. So without further ado, I'm going to play this video, and we'll see if I can get this to work. So the foot flattens to absorb shock as it strikes the ground. Three distinct motions happen at the same time. We call the flattening motion of the foot pronation. It looks something like this, and virtually everyone pronates, and there's nothing wrong with that. Pronation is movement of the heel. We get flatter, and the heel tilts off to the side, the foot points outwards, and then the arch itself gets flatter. In nature, we're meant to promptly unpronate or unflatten our own foot by ourselves before taking our next step. We'll use 30 muscles in each leg and foot to move the 28 bones of the foot back into a more rigid upright position. Typically, we unpronate the foot in nature by pressing it into the ground, leaving behind footprints. We call that supination. So we're meant to supinate, or unpronate, or unflatten the foot into a more rigid upright position to lock the joints, especially behind our first toe bone, so that as you rise up onto the end of the foot, you can push off and take your next step on a nice rigid foot with about half your body weight or more on the end of this big, strong first toe bone. When we look at a model of the foot, you can see how big your first toe bone is compared to bones 2 through 5. It's short and stout, the joints behind it lock to give you a rigid lever to push off on. So to summarize, we flatten, unflatten, push off on a rigid lever, and without any conscious effort, we'll use 30 muscles in each leg and foot to bring the 28 bones into a better aligned position, typically leaving footprints in the ground. Problem with the foot in the modern era is the ground is very hard. You strike the ground, you get flatter like you're supposed to, and then you may get stuck here. These muscles will try very hard to unflatten the foot, but if they can't because the ground is really hard, or because you're striking the ground harder, like when you're running or walking, or if you've been on your feet a long time and your muscles are tired, if you're forced to function in this flat or pronated position, this is where most of our problems occur. So I hope that, my excessive blanket there was a long day. I shot this at the end of the day. My eyes were pretty tired. Didn't distract too much from that. So this idea that there's nothing wrong with pronation. We're meant to pronate. If the foot doesn't pronate, we run into a whole bunch of other problems. I joke with my really rigid cavus feet that come to see me that they don't absorb any shock at all. And Louis DeCaro likes to call them chandelier shakers to make a lot of noise when they're walking around the house. And so the foot is it's meant to go from mobile adapter to rigid lever, but it does it effortlessly for the more part. I say 30 muscles. You can count them. Maybe there's 31 or 32 or 29. It's somewhere around there. And I like to count the sesamoids and say 28 bones just because people are impressed with really big numbers. But it's this idea that the foot is undergoing this motion. I think when they're sitting in the chair and watching it, it makes a little bit more sense, especially when I'm focusing on problems like in the frontal plane, because I'll go back to this idea that, like we mentioned, as the foot flattens, the heel tilts off to the side, and we control the foot predominantly from the frontal plane. And so if we can do proper extrinsic posting with the rear foot of a custom orthotic, we can reduce to a tremendous degree the pronation of the foot. And everything else that we're doing with the orthotic is secondary to that. I really believe that. So Moving on. So I want to talk about a few common pediatric foot pathologies that we encounter. I was going to start with intoing. And I did get permission from all these patients to use her videos. This is a super adorable little girl. She doesn't into that much. She has some much more impressive intoers, but I like her exam or her gait. I shoot a gait analysis like this walking down the hallway on every patient that comes to see me for any reason at all. So if you come in with a wart, you walk the hall. If you come in with toe fungus, you walk the hallway. And it's amazing how sometimes we can see things that are unexpected. And sometimes I'll bring it up with patients. I'll be like, have you ever worn a custom orthotic? You do this thing with your feet. And they're like, no, but I'm really interested. And so it is funny. Patients don't always communicate things well with us, what they're coming in for. And I just love watching people walk and looking for different pathology. So let's take a look at this girl's gait as she walks
And
down the
walk
hallway.
nice and quick. Perfect.
Well, that's my office manager letting her know what to do. So sometimes on the way out, you don't see it as much. You'll see it a little bit. And then on the way in, you can see her feet here in towing. Okay. What a great big smile. And you can see at the very end here, her foot is pointing in. And we'll look at a few things. So in towing, by definition, is an angular variation of the lower extremity seen mostly in infants and young children, in which the feet point inwards. When we catch this like at birth, a lot of times they'll treat it differently and they'll use a tool like a Dennis Brown bar in a child that's non-ambulatory. And occasionally it's really, really severe, like with hip dysplasia or things like that. And they'll, do other things. But, I typically don't see those children. I know Lewis does. I see predominantly kids that are walking and parents are like, wait a sec, my kid's pigeon-toed. Is that normal? And it's like, well, come and see me. I don't think it is. And so three common causes of in-toeing include metaductus. It's a C-shaped foot. Again, I don't see a lot of club feet. I'll see maybe like a unilateral developmental club foot occasionally. There's a big club foot clinic here. I know that Mitzi Williams, who just recently had a birthday, happy birthday, Mitzi. She comes to our conference and talks a lot about doing club foot procedures, Ponseti, as well as things that they sleep with night braces. She's absolutely brilliant. If any questions about club, would talk to her. So we see metaductus sometimes. I'll see this even like one of my nephews has a little bit of a hallux varus, and so we'll see them in towing when they're walking around, and it's actually not an angular variation of the leg; it's more the foot, and those are things that we can correct usually with shoe gear and things like that. Internal tibial torsion is one of the reasons for in towing. That's where the deformity is present beneath, below the knee only. So you'd see when they're walking, the knees face forward, and when they're sitting in the chair, the knees will face forward and the feet are pointing in. Sometimes I think when it's unilateral, quite often it is, more often internal tibial torsion in my experience in clinic. And so these guys, you kind of see that. You can kind of look at the knees. And then the final one, which I think is by far most common cause, will be femoral anteversion. That's a deformity which originates in the hips. And, there's some great photos of looking at transverse plane sections from top to bottom of the hip rotation relative to the pelvis. And basically, it's just rotated a little bit differently. And so we'll see the knees winking inwards. And you can see on her that knee is winking inwards. So she is, part of most of these kids are going to come and see with femoral anteversion. It doesn't really matter whether it's femoral anteversion or internal tibial torsion. We usually treat these about the same way. So once they're in ambulatory age, occasionally my orthopedic colleagues will put them in a Dennis Brown bar, and I've never used one. I know that some people use them with success. I apologize if you use them and I'm being rude, but I think they're a little bit barbaric on kids that are a bit older. And it's funny, we can correct this typically just with a gait plate modification to an orthotic. So a gait plate, that big arrow points to the fifth toe, so it's kind of pointing outwards. And orthopedic literature asserts that the deformity should naturally self-correct by about age 7, but what if it doesn't? So parents are oftentimes told their kids are going to outgrow things, and this one they might outgrow actually. But it seems that they're really excited when we give them an option to do something actively to address this. And so use of a custom orthotic with a gait plate to promote out-towing may assist the expected natural correction of deformity. We can't prove that it wasn't going to derotate on its own. But we're trying to actively derotate it using these guys. When they put these in their shoes, kids' feet will point more neutral. Okay, they'll point straighter ahead. And obviously, when they take their shoes off, they're going to in-toe still. But when they have these, that's the idea is when they're walking on, it's just promoting this rotation that's taking place. these kids' bones are bending and twisting and doing all sorts of things. We see them rotating into valgus a couple times and rotating back to neutral a couple times during childhood. And so these are developmental things. We're seeing these bones doing this, and this is just kind of assisting that to take place. If a child has a in-toe and gait on one side, I oftentimes will do a gait plate on both because we don't overcorrect with these. It's going to bring them to neutral. It's not going to out-toe them. And so, especially if one is more severe than the other, and just like symmetry, I'll do it on both. And typically kids really tolerate these pretty well up until they get really big, like age 13, 14. By that age too, like their bones are pretty much done, all their rotation is difficult to correct, but usually I see them much earlier for this. And I love seeing early walkers because they're much more elastic and they're going to correct much easier. And so they're getting the benefit of the orthotics as well. What are some of the problems with in-toe and gaits? As we run faster, as our speed increases, our gait gets narrower. And so these feet are more likely to contact at the toes. And so a lot of times parents are like, yeah, my kid's like really clumsy. I don't know. He looks like he's pigeon-toed. And so their kids are having fun with their friends playing around. And as they get more coordinated, they can move faster. They're falling down all the time. And so we put the orthotics in their shoes. And that way, when they're wearing shoes, they can run around and not fall down as much. I mean, their kids are going to fall down. So those are some of the things that you're looking for. Correcting in-toeing and custom orthotics with the gait plate extension work great. In general, I like to use the Roberts Whitman platform for my lab, which is kind of a medial lateral flange type orthotic. I love doing these shorter. I don't do them full length typically because they're easier to move around between shoes. I get to pick what color of puff that I put on there, and kids, it usually doesn't bother in the edge of the shell. They'll sit just fine in the heel cup of the shoe. And so I'll typically do this with a Roberts Whitman. If a child needed a UCBL, I'd never ordered a UCBL with a gait plate extension. I'm sure it could be done, but we're usually not worried so much about the frontal plane pathology in children. In this case, we're worried much more about the in-toe and lead eyes. Worry more about frontal plane pathology later on. Next, I'm going to talk about a super common pediatric pathology. This is hypermobility. And, when we look at this kid, I mean, he's basically sitting on his navicular and he's everting quite a bit. Now, Louis Sicaro brought up at a conference this idea that Massey proposes if we could ambulate at birth, we would be about 7 degrees everted. And we're going to shed 1 or 2 degrees of eversion every year until ideally around age 4, 5, 6, when we're in a standing position, our heels are vertical. So we see this, a child who's 3, who's standing and they're in a little bit of valgus is pretty normal actually, but they shouldn't be walking on their navicular. A flat foot is pretty normal up until their arch develops around age 4 or 5. And so, but as the valgus, when it persists after about age 5, becomes a bit more of a problem. And so you see these kids that when you're evaluating them, they're not just a hypermobile first ray, but they're inverting and everting much more than the 20 and 10 degrees we expect, sometimes maybe even 60, 30 degrees. And so if the foot moves out of position more, then the effort it takes to realign it is also greater. It's just kind of a general rule that I think there's some feet that have different supination resistance based on different things like the position of their subtalar axis. But in general, we're going to see these really floppy feet becoming kind of an exhausting foot type. And so I oftentimes use this this analogy. I tell patients that when their child with a hypermobile foot is playing with kids that have less mobile feet in the field, it's almost like their friends are running in the grass and they're running in the sand. They're going to go a little bit slower and they're going to get tired a lot faster. And a lot of times these kids, and so you'll tell this to parents, you see lights going off. They're like, oh yeah, like it's, and kids are like, yeah, I totally feel that way. And then, these are kids that when they go shopping with their parents, they're complaining about foot pain like 10 or 15 minutes after being there. And their parents are like, we just got here, like just chill out. And when we go to an amusement park, you're going to see these kids getting carried by their parents in line. And so they're just like their feet move out of position more, and their feet are just desperately fighting against the ground. They're getting really exhausted. And so this is a funny thing that a colleague of mine said that they would assert that there's no such thing as growing pains. I have a patient who's 9 years old and she's 6 feet tall and 200 pounds. She has a pituitary gland tumor. She probably gets growing pains, but most kids in the traditional sense probably don't get as much growing pains as we think because our arms and our neck grows and they never hurt, and why should our legs? And a lot of times these kids are experiencing remarkable pain in the tibia fibula area due to the 11 muscles that are attached to those bones that are just desperately fighting to supinate these super mobile feet. And so, we get these kids with really bad growing pains. We put orthotics in their shoes and they magically disappear. And unfortunately, our primary care doctor colleagues are just going to write it off all the time. Like, oh, it's just growing pains. Don't worry about it. And it may not be. And so ask these patients, does your kid get growing pains a lot? And they're like, oh, I get them all the time. I'm like, I think we can help with that. Um, custom orthotic is going to limit this pronation and also encourage proper supination. So the muscles aren't desperately fighting against the ground all the time. They're simply moving the foot the way that they should. It's like these kids have a marshmallow at the end of their legs. So it's wicking a huge amount of energy. They're running with the same amount of in exertion as their other friends, but their friends are going way faster. They're trying to coordinate motions, like planting on one foot, kicking a ball, and their foot's moving all over the place. Like it's something that orthotics for these kids can do a whole lot. And so it's really exciting when you get these hypermobile kids in orthotics. They get really attached to their orthotics. Like they do not want to take them out of their shoes. They will not wear shoes without them. I get kids that are 8 years old who won't go to recess until they switch them from their indoor shoe to their outdoor shoe. Teachers hate me for it. Sorry, guys. It's hilarious because these kids, they're just like so attached to the orthotics. I remember having a mother who was really critical of orthotics in general, bring me her son who was just remarkably hypermobile. And we put him in orthotics. I think at the time he was age 8, and but he was really hypermobile in the frontal plane. These kids I will use an UCBL type of device with the deeper heel cup because we're trying to correct that frontal plane so much. And so I usually use it up until 8 or 9. I don't use it much later than that typically. And we're hoping that over time that the connective tissue may mature and they have less hypermobility, which happens quite often. But these kids, this kid, he came back a year later with his mom, and I was like, I was quite worried. I was hoping that things went well, and I was like, hey, how did he do with his orthotics? And she's like, you know how he did. I'm like, tell me. And she said, he refuses to take his shoes off around the house, and he once asked if he could sleep with his orthotics on. And so stories like that really warm your heart. These kids, when you catch them when they're later, like age 13, 14, you can fix the foot, but they are done playing sports. They've been picked last for sports their whole life. They've just got this foot that's killing them quite often. And so if you can get them early, they'll have a much more normal experience with other kids. And that's the idea. Again, we're trying to help the foot function like it would barefoot in nature. These guys are really impacted negatively by hard surfaces. And so we're helping improve that function. And it just works amazing. So I love treating kids with remarkably hypermobile feet. Occasionally, you're going to run into kids whose hypermobile feet, the connective tissue does not mature over time. Those are usually our connective tissue disorder kids. And often it runs in the family. Patrick Agnew, a former president of ACFAP, he's done a ton of work on connective tissues disorders. And he'll if you come to our conference, he'll teach you the 9-point screening test for it. And quite often we see these kids score like an 8 or 9, and then mom scores an 8 or 9. We'll talk a little bit about what that means. But for them, it means that they'll probably always benefit from a custom orthotic, and probably everyone in the family will. It is a pretty common genetic trait that we'll see in those families. And so if you see these really hypermobile kids, where everybody in the family, especially the parents, are really hypermobile, you can think about things like a connective tissue disorder. Now, this girl's bunion doesn't look that impressive in this photo. I wish I captured it better. She's 7 and she's already got a toe underlying the second toe. And when she's in person, it looks pretty profound. So I wanted to talk about the juvenile hallux adductor valgus or bunion and what role do orthotics play for these kids. So these juvenile or pediatric bunions, they occur 7-to-1 female to male ratio. I think that's conservative, maybe even higher. I don't see a lot of boys with this. Average age of onset is about 11.8 years. Again, I see them age 7, 8, but quite often it's adolescents around age 14, 15. A family history is present up to 90% of patients. Typically, maternal transmission is an autosomal dominant trait with poor penetration. So sometimes you get families where literally everyone has a pediatric bunion, and sometimes you get one where like a great aunt had one. And so it doesn't mean that you're not going to always see that perfect penetration of that gene, but it is something that they may pass on to their kids. When you see an adult who comes to see you and they've got a bunion, they're 30 years old, You can ask them like, hey, what age did you get this bunion? They're like, oh, I got it when I was about 12. They're like, well, do you have any kids? Oh, yeah, I have three daughters. Well, how old are they? No, they're 3, 6, and 9. Why don't you bring me the 6 and 9-year-old and we'll take a look at those. We may be able to prevent this as they're growing. Um, so typically in biomechanics, we think that bunions are acquired over time due to the foot functioning in a pronate position to a great extent, right? There's certainly a genetic quality. I know that there's been some literature that shows that pediatric bunions may have a different morphology, the head of the bone. So it's kind of like newer literature emerging there. But we still think that in general, we acquire bunions over time because in a pronated position, we get an imbalance of the muscles attached to the great toe, and the adductor, it really overwhelms the abductor. And so we get this pulling towards the second toe. Obviously, there's things happening in the frontal plane. There's a lot of other factors, but that's the primary deforming force. And so treatment with a custom orthotic allows the foot to function in a neutral position, which we're trying to balance the adductor and the abductor. It should slow or stop progression of the bunion and especially facilitate first MPGA function. This is such an important joint in the foot. We do want to bear quite a bit of weight on this bone. And so with a bunion, it makes it more difficult to load. And orthotics can help load weight onto that bone the way that it should too, which can help with a whole bunch of lesser metatarsal pathology. So I basically tell parents that like, if you have a child, you're seeing me, they have a little bit of a bunion growing, or you have a family history of bunions, especially in the girls, wearing a custom orthotic, what if it prevents them from getting a bunion? It would be really hard to prove. We'd have to treat one foot and not treat the other foot. But it is something that like, it's just one of those what if questions. And so a lot of times these kids with the bunions, they'll wear orthotics essentially their whole life to try and keep this from progressing, try and improve its function. I'm a believer that if we can keep a bunion symptom free, as long as they can wear a wide enough shoe, it doesn't need to be corrected surgically. But obviously, some people that do surgery are going to approach it a bit different. I'm not opposed to it. It's just up here, I don't get to do bunion surgery anymore, so I do it mostly with orthotics. So that's the idea. That's how I explain it to parents. And so virtually every child that comes to see me with a pediatric bunion leaves my office with a pair of orthotics in their shoes. Lastly, I want to talk briefly about calcaneal apophysitis or Seaver's disease. And I'm just going to touch on it briefly. There's so many things that we can do to treat this, but the orthotic is probably the most important thing. And why is it important? I know that this kid looks like he's 7 feet tall. I don't think he's quite that tall. He's 14 years old, though. I really wanted his gait for two reasons. You can see when he's standing, he's in quite a bit of valgus. And the easiest way to describe this appearance is when the heel is functioning in valgus, the growth plate is like rubber cartilage, allowing kind of connecting two different bones together. And those bones eventually will fuse into a single bone over time. But the growth plate allows it to grow on either side. And so as the heel is out of position in valgus, we're getting shearing of this piece from that piece and creates inflammation across the growth plate. Louis DeCar brought this to my attention, this idea that this transverse plane, really medial heel whip that can take place while they're walking for a number of different reasons, can cause this as well. And sometimes you'll see this in a person with a cavus foot with a nice varus heel position. They're not even rotating into valgus at all, and they get really bad Seavers. And this kind of explains it for them, especially when they're wearing a cleat. So imagine if a cleat is stuck in the ground and the foot is whipping against it medially at the heel. So let me show you what that looks like. This kid has the biggest medial heel whip or abductor twist I've ever seen. Watch those heels as he walks. This forceful inward rotation as he goes into propulsion. So it's a late mid stance type thing that's taking place. You can see it on the way back. These things are just, so if that cleat is planted in the ground, he's going to tear that piece of the calcaneus off of the other piece. And so if we can use an orthotic to bring weight back onto the first toe bone, as Bosch and Moeller would say, using high gear instead of low gear. I like to look through things through the lens of functional oxidative, which I know is heresy to some other people, but we're just talking about how we are meant to bear a lot of weight on the first toe bone. And things happen that cause us to load weight onto the lessers, which is often accompanied by this abductory twist. And so as we can correct that with an orthotic, these people do great. For somebody like with this much of a medial heel whip, I might produce a full length orthotic with a kinetic wedge. That really drops that first metatarsal head into position, really facilitates the proteus longus to help us bear weight properly on that bone. And quite often this will significantly alleviate that transverse plane rotation taking place. So It's a traction apophysitis of the Achilles to the insertion of the posterior heel, most common in boys 10 to 12 and girls age 8 to 10. So excessive pronation, heel eversion plays a role. A tight Achilles definitely plays a role. And quite often, if I have a kid who has really tight Achilles, we'll address it prior to doing an orthotic, because the orthotic will eliminate their compensation mechanism. When the foot pronates, it kind of gets about 7 degrees of false dorsiflexion. So movement at the subtalar joint because of its axis. And if the axis is in different positions, it might be more than that. So if we eliminate that, it can cause more problems of a tight heel cord. I know that I can talk about products that I use because this isn't a CME lecture, and I quite often will use the Aquinas brace by EQ Medical. It is just a fabulous tool to lengthen these guys. I know a lot of people try to use a night split, and it can work, but the Aquinas brace is going to stretch the gastroc as well as the soleus, and I've had a lot of success with that. So I would address the Aquinas prior to doing an orthotic on these guys. But an orthotic is a really critical piece of the puzzle for Seaver's disease. Kids just do great with it. So again, I'd probably put something like that, especially in their cleats. Will make it a narrower profile, make it a little bit thinner, so they can fit into their cleats, and it makes a huge difference for these kids. When we're doing higher impact activities, we're putting like, up to 8 times body weight force to a single foot sprinting, maybe 8 or 9. And so we want to protect them when they're doing those really high impact sports. So if we need to make it smaller to fit into cleats, it makes sense to do it. Okay, so to finish, like I mentioned, I just want to ask a few what ifs. So, what if a child wearing a custom orthotic during foot development allows connective tissues to mature with the foot in a more neutral position? So, as those connective tissues become less flexible, what if they develop a better adult foot type? Okay, it'd be really hard to prove, but it's a big what if. What if children wearing custom orthotics during foot development limits first ray hypermobility? Is that heel is in eversion, it just tends to want to drive that first ray, further into dorsiflexion, and so it may keep that connective tissue from becoming less hypermobile. And so it is something that, like, what if we can help with that? I saw a woman today with progressive flapidiformity taking place on one side, and it's something that what if we could get these heels to sit into their more neutral position rather than eversion? Would it lead them so that they're less likely to develop these things as an adult? It's a good question. And then what if children wearing custom orthotics during foot development improve their adult foot type or improve adult foot function? It's all about function. And so that's one of the big questions. And that's what I look at it as when I'm talking to people about custom orthotics, and they're kind of on the fence because they're like, well, we have some coverage, but it's not great. How important are these for my child? And I'll be honest. I mean, if their child isn't that mobile, sometimes they bring me 2 kids, and one of them is super hypermobile, the other one's not. I'm like, listen, that one needs him. He's a 10, okay, and he's gonna love him, and he'll be grateful for him. And if this one, he's probably a 4. And I think that almost every kid's gonna benefit from orthotics. Some will benefit more. I try to be honest about that, but I don't. If they need them, I try to be honest about it too. Parents will make sacrifice for their kids they won't for adults, and it's amazing to see how well these kids do with orthotics. They just love their orthotics. If all I could do was see kids in orthotics for a living, it would just be the most amazing practice. They are the happiest patients on the planet. They just love their orthotics. So in conclusion, pediatric custom orthotics will improve the natural foot function in the pediatric foot, which is negatively impacted by the ground we walk on. We have a ground problem, not a foot problem. And so some feet are negatively impacted by it more than others. And so it is something that we're trying to make up for the ground. Pediatric orthotics will assist in treating a variety of pediatric foot conditions, a whole bunch of them. They're going to reduce stress on tissues, promote proper maturation of the foot and skeleton, potentially improving that adult foot structure and function. And then they're going to improve performance. These kids, you put them into their shoes and they'll increase their stride length. They'll increase their acceleration, their top speed, their vertical leap. It'll help them coordinate movements. A lot of these kids, they come back and see me and they're like, yeah, I put the orthotics in my shoes. And the first time I wore them, I feel like there were jets in my shoes because they're putting in the same amount of effort they've always put into it, and they're getting more out of it. They're getting what the other kids are getting out of it. And so it's really exciting when kids have those kind of experiences. And they should be comfortable. Like I mentioned, if they're not comfortable, work with the child. If you need to reduce correction, height, if you need to make it full length because they have some sensory issues, like whatever you need to do, you can make whatever modifications are necessary. These children should really miss the orthotics when they're not in their shoes. So If anybody's interested in my references, I'd be happy to send those to you. There's a whole bunch of references out there. This is my beautiful wife and my two hilarious daughters. They're 4 and 2, Autumn and Allison, and we're just hanging out at the Vancouver Aquarium. So I just want to leave some time for questions if anybody had questions, Anne.
Well, that was awesome. I really appreciated everything you included. I thought it was one of the greatest presentations I've ever seen.
Well,
So I
thank you.
am now your biggest fan. Okay, so we do have some questions. So one came in the chat, so I'm going to read that one, then I'll flip over to the Q&A. Just as a reminder, if you have questions, put those into the Q&A box, not into the chat. So one of the questions is, what modifications would you make for this kid? And that was at 8:35, so like 10 minutes ago. Do you know what kid you might have been talking about? Okay, well, we'll wait for that to come in. While we're waiting, is there a max age or weight in which you use a medial flange for hypermobile child? Seems like they don't tolerate the flange blisters, pain, etc.
So it's interesting. I was attending just like a local orthotics manufacturer lecture, and Douglas Ritchie was one of the keynote speakers, and he made a very controversial proposition. He let us know, he's like, listen, this is going to be controversial, but I want you to go home and think about it. He's like, a medial flange pronates the foot and a lateral flange supinates it. And I was like, you got to be kidding me. Like, I always put medial flanges on all sorts of things. And so when you think about it, I'm not saying that a medial flange is like super pronates the foot, but you think about a lateral flange trying to keep, especially if their neutral position is a little bit of varus, we're going to maintain them in varus so much better than a medial flange, which almost wants to push them into a little bit eversion. And then what is his name? Well, one of my favorite biomechanics thinkers, who I can't think of his name right now, from California, he talked about how if their axis of the subtalar joint is excessively medial and you have a flange that crosses it, it'll cause pain. And I was like, that's really interesting. And I had a guy that we were putting flanges on his orthotics, and he was tolerating them. And so he came and saw me, and I just shed the medial flange on all of them, and he just loved it. Like, I first did it on one pair, and he's like, oh, like these feel so much better. And so we brought in like 4 other pairs of orthotics, and so I don't put medial flanges on. That they're like, who is that guy? He's written about 6 books on biomechanics. They're sitting on my shelf. They're at my office. I can't think of his name, but Kevin Kirby. I apologize. So Kevin Kirby does a lot of stuff talking about where is the axis of the subtalar joint? Is it medial or lateral? And when it becomes excessively medial, it makes it very difficult for them to supinate. They're way out of position. So you see this in these really, really everted flat feet. And so he would propose that when you're correcting those, focus on the rear foot position. See if you can. He recommends the Kirby Skybe, although people that are prone to plantar fasciitis, I think it kind of irritates that. But if they don't, I Skybe a lot of people, and then maybe like switch them, shift them a couple degrees into varus, shed that medial flange and put a lateral flange to buttress that lateral foot and maintain it in that position. And people tend to do really well with that. So I like that question because that's a controversial idea. Douglas Ritchie is a pretty smart guy. Okay, he might be like, he can talk biomechanics on a level that I do not understand. We ask him some questions sometimes, and it's just way over my head. Like, that dude is really smart, and it was interesting for him to bring that up. This idea that maybe we shouldn't put medial flanges on things as often as we do. I use lateral flanges all the time, so it's something to think about. That lateral flange may actually be causing pain if it's crossing that subtalar axis, if it's quite medially deviated.
Great. If the patient only has one side in toe, do you prescribe gait plates for both feet?
I do. And you see that, like I mentioned, I think I see it more often when it's internal tibial torsion. I don't see it as often as femoral anteversion. It tends to be both. But I do, because I like symmetry. And like I mentioned, that gait plate will not overcorrect, but you don't want a kid feeling something different in both shoes. I want them feeling about the same thing. I do this with neuromas. I do this with a lot of things. I'll put a met pad on both orthotics. I put a kinetic wedge on both orthotics. I don't want people feeling asymmetry unless it's absolutely necessary. You want them to have a similar experience, because sometimes something might be a little bit uncomfortable, but they don't know it's uncomfortable unless they have something to compare it to. So if they have nothing to compare it to, they just kind of get used to it. And so I always do a gate plate on both of them.
All right. If the patient has both hypermobile flat feet and into. Can you do gait plate with UCBL type orthotics to address the flat feet and the into?
That's a good question. I've never asked my lab to do it. I don't know why you couldn't though. It's funny. My lab has a few like pediatric basic orthotics, and so they'll have UCBL, Roberts Whitman, and then they have a gait plate that's separate. And I kind of joke, I'm like, well, I'm not going to order just the gait plate. I want at least a Roberts Whitman, and I don't see why not. From a functional standpoint, there's no reason not to do it. Sometimes I've asked for a Robert Switman with like a deeper heel cup. So it's basically like a UCBL anyways. And they change the height of the UCBL heel cup based on the age of the child or the size of the foot. And so it's not always the exact same size anyways. And so I think scaling up the heel cup to address that is a wonderful idea. Yeah.
How do you feel about the non-custom FOs if there is an insurance coverage issue?
And it's a good question. Like I mentioned, the head of the American College of Foot and Ankle Pediatrics is Louis DeCaro, and he's done a ton of lectures with you. And he's talked a lot about the Nolaro system that they have and Little Steps. Little Steps are a prefab UCBL basically. And he does some cool stuff with it. If you go to his website, you can print off a page that you have the kids stand on. And he's got a bunch of size of feet tracings, and so you can figure out what size they are. It's a bit of a mystery sometimes. You're like, how do you measure these kids' feet, And so he's like, oh, she's an 11. I thought she was an 8. So you get an 11 little step and put in her shoe. It's a prefab. It's more expensive than like a power step, but it's much less expensive than a custom, and they function awfully good. And so unless they have some rigidity or like a really unusual foot type, they're going to do well with that. And so if you're looking for a pediatric prefab in general, the little steps. I had a mom and daughter come and see me once, and they were both wearing little steps. Mom had kind of a smaller foot, and she's like, yeah, I've been wearing these for years. Are they okay? And I'm like, that's an awfully corrective orthotic for an adult. But if you can tolerate that, stick with it. Yeah, Forrest, and it's a fabulous idea. Like I mentioned, I have with a custom, we can get into like the minutia, like what exact, forefoot to rear foot position do I want to do? Do I want to do things like extrinsic posting or things like that, which we don't have that benefit. Although you can modify some of those over the counters as well. But kids, you've got a margin of error that's much bigger than adults. And so if you're not exactly where it's supposed to be, but you're awfully close, they're going to tolerate it just fine.
Do you do heel lift modification for Sever's disease patients?
That's a good question, right? Like, and I'm not opposed to heel lifts. Like I mentioned, I'm more a big fan of trying to correct the equinus, which is not easy in older kids, right? So younger kids, they're more elastic. There are some people, so the guy that's done a lot of work on this is Patrick DeHere, and he usually gives an Aquinas lecture, and we'll have to have him come on to the webinar, and he's done like 1,000 lectures, Patrick, but he's probably one of the worldwide leading thinkers in Aquinas. He's just brilliant, and so he developed a tool called the Aquinas brace. Take a look at it. So if they're like 12 or younger, and you put them in the Aquinas brace over the course of about 1 to 4 months, you can actually lengthen that connective tissue. And so the reason I used to use night splints, I have kids sleep in them, but they're only really working on the soleus at the knees bent, right? And so the Aquinas brace is going to actually lengthen it. So you have these kids use it, usually within a month or two, they're getting closer to 90 degrees, which will give them relatively normal function with the orthotic. That's when we'll make the orthotic, we put it into fabrication when we fix them, but then they continue to use the Aquinas brace maybe weekly forever. And fixing that Aquinas, it fixes so many problems. Like I mentioned, it's going to lengthen stride. Aquinas can directly cause lower back issues. It destabilizes the limbs, and so we're able to keep that heel on the ground further through the gait cycle, and it does magnificent things for the foot. Like I mentioned, Aquinas causes the foot to pronate as a compensatory mechanism. So if you can fix the Aquinas, it would be ideal. But am I opposed to heelless? I'm not. The problem is, shoe fit isn't always as good. They're sitting in that heel cup of the shoe a little bit differently. And so if you really can only go up to about 6 millimeters or a quarter of an inch with a heel lift. But if it's an older patient or you just cannot seem to get them out of Aquinas and you're using a heel lift, like do it. I'm not opposed to it. Even if you want to do it in the short term, say you don't put it into the orthotic, but you put one on there while you're working on with the Aquinas brace, it's a genius idea, right? Because you're going to be able to make it so it's non-contributory to the pathology you're correcting, and then we'll correct that one over time. So rather than waiting to correct it, you're kind of doing it at the same time. So I use heel lifts for things like Achilles tendonitis all the time. And I know people that use them for plantar fasciitis when equinus is an issue, and they're using them temporarily. And then using something like the equinus brace to try and train them out of it is a great idea. Good question.
What is the best way to address a adductory twist in a prescription? Did you already answer that one?
Well, it's a good question. So I remember I was at a conference, and this was like it was someone like you, Ann. It was someone who wasn't a podiatrist, but who worked for. They were probably a podorthist working for a lab, and they knew so much stuff. I mean, you hear so many things, and so he was giving this little preamble between lectures during like a break, and he's like, "Listen," he's like, "the guys on the West Coast, they." Activate the windlass mechanism when they're scanning feet orthotics and other people don't. And he's like, and the guys on the West Coast, I shouldn't say guys, the people on the West Coast, I apologize. The people on the West Coast, they'll do a deep cutout for the first MPJ. And other people don't. And he's like, and what do we see with their results? He's like, we're just seeing better ambulation on that first toe joint. Do I use a kinetic wedge on everybody who has that classic long, thin callus in number two, big rounded number five, and callus, medial pinch callus on the first, who's complaining about metatarsalgia or things like that. Like, I don't use it on all of them. I use it on a lot of adults. I see if they tolerate it. 1 in 5 will not tolerate it, but about 3 out of 5 just absolutely love it. But doing like I do a J-shaped first MPJ cutout on virtually everything, and everything gets at least a fifth MPJ cutout. I do a lot of fifth ray cutouts as well, because sometimes that forefoot supinatus, sometimes it's an uncompensated forefoot supinatus. So it's not a genetic varus, but it's an acquired varus. Like it's a supinatus that won't compensate to neutral when the rear foot is in neutral. And so a lot of times I'll chop off the fifth ray. So we're putting less stress on the midfoot. We do things to try and drop that first met head down. So that's really what you do. If you can bring weight onto that first met head, it's this compensatory lack of motion or weight bearing there as it loads onto the second and other ones that'll cause the foot to rotate. It just pivots on that second toe bone. So that's the primary way that I try to get them out of it.
All right. 18-year-old D1 basketball player with hypermobility, valgus heel with significant medial column collapse. Discuss orthotic features, including heel cup depth, materials, and materials.
Yeah, no, this is a good one. So how much does he weigh, would you guess? Let's say he's D1, so he's probably about 200 pounds, we guess, okay? I would use a material that's good for someone who's at least 50, 60 pounds heavier. So we're going to use a pretty stiff one because he's hitting the ground awfully hard, right? He's got a lot of force. When you're sprinting, you're putting so much force. So we want to be a pretty rigid shell. If his neutral position, if you can get him to neutral, like perfectly vertical, I'd still post him 2 degrees inverted. I might consider a Kirby skive as long as he doesn't have a history of plantar fasciitis. And then I wouldn't put a flange on it. It sounds like the craziest thing. I put a lateral flange, probably cut out the fifth ray. He's probably got like a wicked supinatus or varus. And then I'll do similar things, and we'll look for if he's having transverse plane rotation issues. It's something you can see when they're walking down the hallway. Not always as much as that 14-year-old, but you can see that medial heel whip. And a lot of times they ask these people, do you get hip problems? They're like, oh, I got crazy hip problems. I had a 30-year-old who had a hip replacement see me once, and she was whipping like crazy. And she's like, yeah, the other hip's really bad, and they think I might have to replace it. And we did some of these mods with the kinetic wedge and the fifth ray cut and deep first MJ cutout. And she comes sees me 6 months later, and she's like, I haven't had any pain in my hips since I saw you. And so you see those things happen sometimes, right? Like if I had seen her as a kid, what if she still had a normal hip? So it's something that like you'll sometimes look for that for pathology further up the skeleton, lower back pain or hip pain, oftentimes related to that abductor rotation. That's what I usually would use is deep in that first image you cut out. When you're scanning them though, I love to, Richard Blake talks about this idea of just gently dorsiflexing the first toe. You're not bringing it into like a full windlass mechanism, but activate the windlass a little bit. It's going to supinate the rear foot a little bit, so you're getting that rear foot capture just a little bit supinated. And it's better for them to sit a little bit supinated than a little bit pronated, right? And so I just gently dorsiflex that first MPJ. I usually have my hands under the sulcus of the toes, not under the MPJ, so under the sulcus of the fifth. It's really easy to load the fifth. You just gently dorsiflex to resistance and it's loaded. And then I'll dorsiflex that first, plantar flexing the first ray with my middle finger. And so we're activating that windlass just a little bit. I know that Kevin Kirby uses fascia accommodations in orthotics. A lot of people love those. I find though that I'm actually making the medial aspect of the orthotic match their activated plantar fascia. So I don't need those. And when I'm fitting it, people sometimes look and they're like, oh, this doesn't match the arch of my foot. I'm like, no, it matches your plantar fascia. Look, when I activate your plantar fascia, the arch of the orthotic is going to match that. If it doesn't match that, it matches your bones. You're going to kick off it every time you're activating the windlass mechanism. It's going to feel terrible. And also, those people need to understand the arch isn't correcting your foot. The arch isn't even important. We can cut the arch out of most of the orthotics anyways. It's that rear foot control, that frontal plane control is doing so much of the work. Then we're doing some stuff at the end of the shell in the forefoot. So
If someone has femoral anteversion and develops PTTD, how do you make the orthotic?
yeah, it's a good question. So again, I'm going to do an orthotic with a gate plate, but we're going to do I'm assuming this is a pediatric patient, so it's a young person, which you do see post-tib issues sometimes, right? And so again, we probably do a deeper heel cup if we can. It doesn't have to be a UCBL, but I might do a Roberts Whitman grind with a deeper heel cup, or if they're a bit older, do a sport orthosis with that lateral flange. But we're really focusing on maybe if they can tolerate a medial scive, I'll do maybe a 4 millimeter medial scive, and that might bring them like a couple degrees more inverted than I see on the scan. So that we're really making it very difficult to evert at the rear foot. And then you just add the gate plate onto that and they'll do great.
Do you increase valgus forefoot post for a gate plate with kids at INTO during your treatment plan?
It was a good question. I do not. In my experience, now you're going to run into some kids that have a complete rigid forefoot varus, but it's pretty uncommon. Yeah, it's funny because like Louis DeCaro has a great lecture about how a lot of these really young intoers sometimes is a cause, or sorry, of toe walkers is actually due to an uncompensated forefoot varus. But no, I typically do not. They usually can get the forefoot close enough to the ground that I'm not worried about that. But you're right. If you're thinking about that, could you use a full length orthotic with a valgus or sorry, a varus forefoot post and a gate plate? Why not? Yeah, I totally do it. See how they do. The gate plate is still going to function okay. I wouldn't cut away the fifth ray like I usually do, but I just do the valgus post, and I think they should do okay.
Um, all right, so we just had one final one come in. Oh, the age of the child. Oh, sorry. What do you do in a soccer player with PTTD that orthotics are not working well? Do you use an extrinsic sport brace and the age of the child is 10?
It's a good question. The thing that is going to help PTD the most is um, an AFO will, okay? But the second thing is an ankle brace. So an orthotic is helpful, but I agree, the orthotic is the foot sitting on top of it. I use ankle braces for post-tib dysfunction all the time. I know that soccer players, it's such a small shoe, they have a hard time fitting it with their pads, but I get them to do it and they'll do it. If they put in a nice, so we use the AFO style, I use the Oster brand, but the ASO style double wrap type of brace is not using big struts, and really have them do the medial one first and really crank on it. Like I'm just trying to bring them maybe 3-4 degrees inverted, Velcro that sucker on there. And so it's going to make it so that they're forcefully, it's really difficult for them to evert when they're pounding the ground. And so I would use the ankle brace on top of the orthotic. The orthotic is the end thing that's going to help maintain that correction. But man, is it hard to get these kids with PTDD out of it when they're still playing their sports. And so the ankle brace, I think, really helps. Obviously, the next level up is a custom AFO, like a Ritchie brace. And it's hard to do for a kid, although I have plenty of kids that are in AFOs. But try the ankle brace out and see if that helps. So sit it on top of the orthotic. The ASO style isn't going to change the bottom of the foot very much. It's pretty low profile. And so it does work quite well like that.
All right. And Dr. Mannheim had a follow-up. Do you have a hard time getting the ankle supports in the soccer cleat?
Yeah, it's a good question. The ASO style are so small in general, but the soccer cleats are so small in general too. if the parents are really serious about it, you might have to tell them like he needs to go up 2 sizes. These kids love wearing one size too small in their stupid soccer cleats anyways. It doesn't make that big of a difference. But the other thing is if you switch them to a baseball cleat, they have more room, and the cleat with the most room is a rugby cleat. And those rugby players still run awfully fast, okay? And so if you put them in a rugby cleat, it's got more room for everything. It's a little bit of a high top, and they play soccer in it. Unless they're trying to go pro, it's not going to slow them down that much. It gives them way more support. These kids, though, if they play once with an ankle brace on under their pads, they'll never play without it. They just love it. It feels so different. They're not at risk of inversion ankle sprains. They feel, that PT tendon is so supported. Like they just love playing with it. So if you can get them to do it once, they'll be okay.
Yeah, I agree. I played soccer in college for the school, and I ended up breaking both of my ankles because I refused to put that stupid brace in the cleat because it just
Oh,
made it so much more difficult. And that was the end of my soccer career. So there you go, live and learn, right?
yes, yes. It's tricky. It's tricky, but yeah.
Yeah. Okay. We have answered all the questions. There were a lot of comments about thank you, thank you, thank you. So as a reminder, it will be available, the recording. And I'm sure if you have questions and you'd like to be connected with Dr. Stanford, you can just email me if you don't have his contact information directly, and I'll send it over to him and connect you guys. So thank you, Dr. Stanford, for being a guest tonight. Thanks for joining us from the West Coast. It's probably earlier out there, right?
I'm ready for dinner, and thank you so much. It's been a pleasure. I really
Yeah.
appreciate, just this casual environment, and I know I'm shooting from the hip a lot. I don't have a lot of research to talk about. It's just clinical practice, and I love this stuff. So it's been a pleasure.
That is what works, clinical practice. So we will see you all next time. Thanks again to our speaker. Thanks to ACFAP for sponsoring, and we'll see you guys next week for our next Monday webinar. Take care,
Thank you
everybody.
so much.
Good night.